small but distinguished group of attendees, and as we mentioned, the proceedings will be archived. We'll distribute the website for that later on. I'm going to begin with just a brief overview of where the county's Opioid Safety Coalition accomplishments are. This is the second quarter of 2018 results for Tuolumne County. And I think, I'm not sure how many of the organizations that are members of the Safety Coalition will actually listen in or listen to the archive version, but I think we have a lot to be proud of, and the accomplishments that are reflected on these charts are especially interesting to me. The one in particular that I'm pleased to see is the bottom one on the left, the opioid emergency room visits in the 12-month period expressed as a rate. The last quarter point was the one way up at the top there on the right. And so since that time, we've had a decrease in emergency room visits for opioids. And I think overall, if we look at the 4 strategic objectives of the California Department of Public Health and the California Opioid Safety Network, I think these results, these data reflect a lot of accomplishments among all 4 of these strategic areas. In particular, the emergency room visit fall and the continuing fall in the prescription OD 12-month death rates, the top left chart or line graph. My guess is that at least in part that reflects our increasing distribution of naloxone and the training associated with naloxone for first responders, for emergency room folks, for law enforcement folks, and so forth. So I think we can be really pleased about this. And there are a number of areas that we want to pursue in going forward. The map is expressed as a rate. Of course, the red area and the orange area are the most populous areas of the county. But if it, as expressed as a rate, it indicates that at least in those areas, something's going on in terms of opioid overdoses. And I think this is an area that we will need to focus on. We're very much looking forward to partnering with law enforcement, the courts, and all of the various partners that are members of the Opioid Coalition. And we'll be having our next meeting. Mary, do we have a date? Not yet. Okay, so okay, so we'll come up with a date for our next meeting, and that'll be an opportunity for us to strategize. So I want to introduce Matt Curtis. Matt, you're okay?
Yeah.
Matt is the California Department of Public Health program manager, if I'm correct, for HIV/AIDS.
Not quite, but so I work in the Office of AIDS as part of our harm reduction unit, and so our team is part of CDPH's sort of AIDS healthcare system, and we're responsible for basically promoting and overseeing drug user health services of a variety of kinds, in collaboration with a number of other parts of CDPH and other agencies like DHCS.
Sorry.
Yeah.
There we go.
And could we do other like introductions for everyone else? I know it looks like there's a bunch of people on the.
Yeah, thanks for the reminder. So let me introduce the VIPs here. So Sarah Kula is the county counsel. Next to Sarah is Neil Evans, who's in the office of the sheriff. Melissa Parrish is our nursing director for the County Department of Public Health. Mary Ellinger is here from the County Medical Society. Mary is the administrative director for the Medical Society. And I'm okay. Diana Lincecum from Anthem Blue Cross, who manages the county's partnership with Anthem. So that's the audience here. Myself, I'm Bob Bernstein, and Paul Maram is our Vista. I don't want to use the volunteer, but he's going to be helping with the Opioid Safety Coalition. I'm the county health officer. Thanks, Matt, for reminding me.
Yeah, and are there other people on the webinar also?
There are a number of people who've been invited and provided with the webinar address. I don't think technically we have a way to introduce among them who's here or introduce them orally. So.
Hi, this is Kismet Baldwin. I'm the county health officer for San Joaquin County. I'm on the webinar or on the phone.
Great. Anybody else want to introduce yourselves? Thanks, Kismet, for joining.
Oh, no, thanks for the invite.
All right. Matt? Andrew Woodruff, did you mention Andrew's the administrator for Plymouth County?
Public Health Agency, here with my health officer, Dr. Mark Satterfield.
Oh, good, Mark. I'm glad you could join. Thanks.
Great to see you.
Okay, so should I dive in?
Yes, please.
All right. So I'm just going to give a kind of quick overview of some of the things that are going on in what we would broadly call harm reduction services in California right now. Talk a little bit about the legal framework for particularly syringe access, but we can talk about other things if that's of interest also. And then a little bit about what our agency does in relationship to these services, how we can support your work in Tuolumne County or San Joaquin for that matter. And we'll have time for, I think Andrew's going to speak after me, and then we'll have time for discussion after that. So Andrew, I think you're controlling my slides. Could you go to the next one?
Yes. Well, let me try.
Oh, okay, great. We got the nice fade thing going on too, which is not built into my slides. It's an extra bonus from Zoom, I guess. So just what are we talking about when we talk about harm reduction? I think, a lot of people will sort of, if they have some familiarity with the concept, they tend to associate it maybe narrowly with syringe exchange or syringe access services. And that's absolutely part of it. But really what harm reduction is an overall approach that draws a bunch of tools together from parts of public health, medicine, and social services, and brings them together under a framework of a particular approach to improving health and wellness for people who use drugs. So, basically the sort of, if you wanted to sort of say who is harm reduction for, we've invested a lot of money and time into primary prevention around drug use. We've invested maybe even more into treatment for people with substance use disorder. For everyone else, those people who are somewhere between I've started using drugs in some way through to I am using drugs in a truly chaotic and unhealthy or dangerous way, that's who harm reduction is for. And so in terms of services, they encompass a lot of things, from the really low threshold stuff meant to engage people and provide basic prevention against disease transmission or overdose. So that includes syringe exchange, naloxone distribution, which Bob mentioned, syringe disposal, recovery and disposal to get used syringes out of circulation safely, safer drug use education. People may have heard a little bit about the discussion around safer drug use services or safe injection facilities, safe consumption services. There's not really one term of art so far. California is likely to enact a law this coming year to allow that to happen in at least one jurisdiction. That would be part of this spectrum. But so are other things that lots of other settings used. So things like motivational interviewing, or policies that do like high quality linkage to care and kind of more structured referral work, or housing access and things like that that get at some of the structural things that can undermine people's ability to protect their health, are also in this framework. Can you go to the next slide, Andrew? And the sort of approach side, there's the sort of intervention side, the particular tools or strategies that are used. There's also what's sometimes called a philosophy or an approach, or just an ethos around how we approach things in harm reduction, that is in contrast to the way that a lot of folks who use drugs experience healthcare or other engagement with systems in other places. So, the kind of foundational thing is just that an interaction in a harm reduction setting promotes health through any positive change. So it's not sort of a black or white, you're either unhealthy or you're, moving rapidly toward abstinence, and there's no space in the middle. There's a sort of a recognition that there are lots of practical things that can be done in that intervening space to help people use drugs more safely, prevent infections, et cetera. And then also these are spaces that come with respect and promote dignity. This is something that a lot of people, frankly, don't experience in other places. People have a lot of experience often with being effectively punished or shamed in healthcare settings, or certainly in law enforcement settings. And what we've found over time is that those kinds of interactions will tend to drive people away from care, reinforce sort of negative patterns that are undermining people's health, and so on. So the approach basically rejects that. Part of doing that is to do services in a participant or kind of, it's very similar in medicine to a patient-centered approach that really values the direct and meaningful involvement of that person who you're working with. So you are basically doing this work in alliance and at the direction, to a large extent, of the people you're serving. You as a provider are there to sort of make sure that every door to positive change is open at all times, but not to sort of twist people's arms or coerce people into doing things they may not be ready or willing to do. That's kind of the basic idea. I think that the one other major thing would be just a recognition that none of this happens in a vacuum. Whether we're talking about opioid overdose, hepatitis C transmission, a skin and soft tissue infection, a mental health issue related to this, none of it is kind of working on its own. And so we have to look at both how we have syndemic issues going on in terms of health, but also how public policy issues and kind of the social environment contributes to these things as well. Next slide, please. So in California, like a number of other places in the United States, syringe exchange started with people, basically directly affected people responding to the HIV epidemic. In the early HIV epidemic, up really through the 90s, a very large proportion of incidents was related to injection drug use. That was certainly the case in places like Los Angeles, San Francisco, New York, Seattle, other places. And pretty quickly, even though the sort of complete science around HIV was still emerging, it was pretty obvious that unsterile injection and syringe sharing was responsible for a number of these infections. So people just started, with no permission or authorization, distributing syringes as a preventive measure. A number of places, including in California, locally began to authorize programs in the late 80s and early 1990s. And then, in California, these programs eventually proliferated. We didn't actually have a state law supporting a framework for syringe exchange programs until the year 2000. But until then, it was really local municipalities were deciding to authorize on their own. And then in 2013, our office at the Office of AIDS was given the authority by the legislature to directly authorize programs anywhere in the state. And that tends to be, local jurisdictions still have the complete ability to do that on their own. But because we have people who staff this specifically, we provide technical assistance, stuff I'm going to get into. Most of the new programs in recent years have been authorized by us, including with the cooperation of local government. And today we have 44 authorized syringe services. I'm going to get to a map in a minute. If you go to the next slide. I'm not sure if it's the next slide. The point I'd make first is just, we're kind of part of this, this discussion around the opioid coalitions around California is, pretty centered on opioid overdose and some related issues, opioid access or overprescribing, some things like that. Syringe services really touch on a bunch of different health issues at once. The overdose crisis has been a big one in the United States in the last 5 years and has really driven a lot of the discussion and the new policy making. There's sort of an obvious, relationship to with the HIV and hepatitis C epidemics. We also, work on a lot of other infectious disease stuff. So in California and elsewhere, harm reduction programs are often interacting with people at risk of or are affected by things like sepsis, invasive group A strep, wound botulism. We've seen is associated with black tar heroin injecting for complicated reasons. Hepatitis A and B epidemics overlap significantly with people who inject drugs. We've seen a national uptick in endocarditis infections alongside the increase in injection drug use. And then skin and soft tissue infections are sort of often overlooked with this stuff, but particularly in places where there's poor access to new sterile syringes, we see a lot of that, and it is a huge source. So it doesn't sort of get the attention of, say, overdose. It is a huge source of morbidity and sometimes mortality among people who inject drugs. Next slide. So I'm going to go kind of quickly through this just to kind of mention, sort of the major sort of, indisputable thing that has happened as a result of the adoption of syringe exchange is just at the point where you see California local jurisdictions starting to institute syringe exchange programs. We see a rapid and sustained reduction of new infections among injection drug users over time. So going from over 40% around 1990 to in 2016, which is the last year of our state surveillance public data, less than 3% for the first time since the beginning of the epidemic. Next slide. We have, had somewhat similar success around hepatitis C. If you look at people, if you look at sort of engagement in syringe exchange over time, or the presence of syringe exchange programs over time in geographic locations, you see a decrease in hepatitis C infection. What's happening though is we're really seeing a lot of, if you go to the next slide, I believe. We're seeing, we've seen this increase in injection drug use among young people in recent years that's really reflected in hepatitis C incidence, where we're now seeing this sort of bimodal age distribution where there's been a big increase in cases among young people. And that's kind of, people are getting hepatitis C before they are accessing syringe services, which is sort of an ongoing problem and something we haven't done a good job of addressing, of getting these services to, or making them appropriate for people who are a bit younger. Next slide. I'm just going to skip ahead because I know I'm going to be careful about time. So how does this work in California? This is a slightly confusing map because it needs to be updated, but basically the counties in blue and a couple cities there are counties where there are authorized syringe exchange programs. that are sort of more long-standing. The green counties are including Plumas, who's on the line, Merced, Kings County, Orange, which has got some complications, are ones where we have authorized new programs recently. Actually, since this map was created, we authorized countywide. There were programs in Sacramento City and Eureka in Humboldt County that we authorized to expand their services to a total of 8 new communities. And then the counties in yellow are where we have sort of active planning underway, including in Siskiyou, which just submitted their syringe exchange application to us about a week and a half ago, largely modeled on the Plumas program, Plumas County application, which was maybe the best one we've gotten in recent times. So there's sort of a lot of this happening. Next slide. Hit one more time there. You might need to, okay. I think that's it. Okay, so what do we do to support this? We operate the Syringe Exchange Certification Program or Authorization Program, where we basically work with local jurisdictions or local community-based organizations or both to basically go through the fairly simple process that I'm going to talk about in a moment to authorize, pursuant to state law, doing syringe services. We also directly and through our partners that we contract with provide a great deal of technical assistance. So if there's sort of anything a new harm reduction program in any setting needs in order to be set up for success, we're there to partner with you and kind of deal with that, whether that means sort of the technical details of how to run a good program or do data collection, or laying the groundwork so that local communities understand the purpose of these programs and how it fits in with common goals and our common values around promoting health in our communities. We also, for authorized programs, we fund a statewide supplies clearinghouse. So we provide all the supplies for free that are necessary. And we also provide for disposal contracting for syringes and a number of other things. I'm seeing Bob, are you trying to wave at me for time, or how am I doing?
No, you're doing very well.
Okay.
I have a question when you're finished, and there may be a question or two, and then we can go on to Andrew.
Okay, I've just got a couple more slides. So next one, Andrew. Let's skip this and just go to next one, please. Okay, so let's talk just for a minute about sort of how to do this. So, a lot of the stuff we do, whether it's naloxone distribution, expansion of buprenorphine access, is closely related to this, but sort of covered in other ways. So I'm going to focus on starting syringe services. And I'll say in addition to the important things that syringe access does on its own, it's also an incredibly important vehicle for accomplishing a bunch of other stuff we want to do. So for example, for naloxone access, we know from the big scientific studies that have been done that the way that naloxone has been shown to reduce population level overdose mortality is by effectively saturating communities of people most at risk of opioid overdose. So while it is a great idea to provide access to first responders like EMTs or police officers, it's a good idea to get naloxone to family members and so on. The most effective by far, and in fact the only sort of population that we have evidence in terms of this mortality reduction, is people who use drugs. And the best way to access folks most at risk has been syringe exchange programs. We're also seeing syringe exchange programs used as there's a huge demand within syringe exchange programs for access to substance use disorder treatment. So we're seeing an increasing trend toward embedding even on-site, buprenorphine induction into syringe exchange programs, because it's just an incredibly effective way to reach people right at the moment where they're ready to do something. So how do you do this in California? There's essentially 4 ways to lawfully distribute syringes. For forever and ever, physicians have been able to prescribe them. This isn't really a practical way of getting syringes out as a public health or disease prevention measure, but it is something that's available to any physician in California. Sort of as an add-on to that, some years ago, the state law was changed to allow any physician or pharmacist to furnish an unlimited number of syringes to anyone over the age of 18 for disease prevention purposes without a prescription. So this means that any doctor or pharmacist in the state currently has all the authority they need to basically distribute syringes to prevent HIV, hepatitis, all of these other things, and doesn't need any additional authority. And the law, specifically protects them from, any kind of liability around that. Next, as I mentioned before, for the past 18 years or so, city or county governments may themselves authorize programs. This has been done in a number of different ways. Some places, like in Alameda County, where I'm sitting right now, the local ordinance says essentially syringe exchange is a legal service in this county. So I could kind of walk outside right now and do it and be doing it lawfully. But local governments have basically all the leeway that they want to impose more restrictions on that by, for example, naming specific organizations that are authorized, or operating locations, or anything else like that. Finally, CDPH, our office in the Office of AIDS, may directly authorize programs. Partly that was done by the legislature explicitly to sort of respond to the need for services in some jurisdictions that were not willing to do authorization locally. But for the most part, we are using this in a less contentious way. I think that, Andrew's going to talk about the trajectory in Plumas, which I think is a really good and fairly typical example of how this has gone. But we have a pretty straightforward process that's detailed on the next and last slide. Okay, so there's a kind of quite simple application package. We ask you to tell us about your plans for the program, when, how, and where it's going to operate. There are certain requirements that are described in law. So we require some additional services to be attached to the syringe exchange program, but the sort of bar is pretty low in terms of the need for funding. But it's some common sense stuff that you would just want to make available in such a setting. Once the proposal is submitted, it goes for a public comment review. We basically post a summary of it on our website. We consult with both local law enforcement and the local health officer in the county in question. And then anyone may provide comment by email over a 45-day period. After that's over, we have another review, and the determination is ultimately made by our state health officer, Dr. Karen Smith. That's basically it. And we're here to sort of help that happen along the way, answer any questions, provide templates for things, and basically make sure it's pretty straightforward and seamless. These services have been established in all kinds of settings. We have syringe access programs in FQHCs. We have them in drug treatment programs. We have the sort of, let's say, traditional, kind of standalone community-based organization, harm reduction model, and a bunch of other, and a number run by county health departments as well. So I'm going to leave it at that because I think questions and answers are more fun than continuing presentation.
So, Matt, thanks for putting up your email address. Would you welcome inquiries from law enforcement or county council or anybody, public health, behavioral health, and so forth?
Absolutely. I and my colleagues are happy to talk to anybody at any time about this. You're also very welcome to distribute these slides if you're sending notes around after this. And yeah, I would encourage people to be in touch if there's anything at all we can do to answer questions or be of service.
Okay, so I have one question, and there may very well be a couple of others. Can you give an idea of what the range of costs across the counties have been to establish these programs? In particular, you listed perhaps 8 or 10 different kinds of services in a syringe services program, and I imagine that the costs for implementing and sustaining each one of those varies substantially. Do you have any data on that, and could you distribute that later?
We kind of have data on that. We do an annual survey of all of the programs that we support through the clearinghouse, and that includes some questions about program budget. But I think the point is, I mean, it's obviously not no cost, but there's not one way to do this. So you have extremely robust programs, like say, for example, the harm reduction program that's part of the San Francisco AIDS Foundation, which has sort of multiple drop-in sites, a pretty big staff. They do mobile outreach. They do a whole bunch of other services, mental health, all these other things. And then you frankly have programs that are like one really amazing person doing effectively volunteer work out of the back of their car, and much that's in between. I think if I was kind of talking to folks about how to get stuff started, we have a big unmet need in a lot of parts of the state. We have a lot of people suffering without these services, and that there are ways to start small and to integrate things into stuff you're already doing that are sort of minimally disruptive and add minimal additional cost. For things like supplies, like syringes, injection equipment, disposal contracting services, naloxone, the state will buy those things for you, so that adds zero cost. We don't, unfortunately, have funding for things that people usually find helpful, like staff or rent or transportation at the moment, so that is a legitimate problem. That I would say is preventing realizing the full potential of this work in California, but that may change in the future. And but yeah.
Okay, thanks. Couple of questions.
Also, just real quick, one thing about people may have heard that there in the past was a federal ban on funding for syringe exchange services. That is true. That ban was almost completely lifted, however, a number of years ago. And so today, basically the ban is on using federal dollars to fund purchasing syringes, period. So for example, we administer a bunch of CDC HIV prevention funding to a number of counties around the state, including San Joaquin that's on the line. And we are encouraging, and a number of counties are doing this, of using some of that funding to support some of that syringe access work. So that money can be used if you have CDC funding, if you have SAMHSA funding, HRSA funding. The health services van in Plumas was funded by HRSA, if I'm not mistaken. That can be used for the sort of infrastructure or staffing or whatever around syringe services.
Anybody want to ask a question on that? Okay, so we have your email address, Matt, and thanks so much for this presentation, which we will distribute the slides. Andrew, how are you doing?
I'm doing just great, thank you.
Yeah, okay, you ready to start?
Yeah, let me see if I can figure out the slides here. All right, can folks hear me okay?
Yes.
Great. Okay, so my name is Andrew Woodruff. I'm the Director of Public Health in Plumas County, and I'm going to take a little bit of a storytelling approach to this and really just share with the group here sort of how we've got to the point we're at now with our syringe access and disposal program. Oops. So for those of you who aren't familiar with Plumas County, we're located north of Lake Tahoe between Chico and Reno. We have about 18,000 residents, and we're quite rural. We have rural and frontier areas and quite mountainous. We're full of rivers and lakes and sketchy roads. Around 2015, in the spring of 2015, when I arrived in Plumas County and took a job as the local AIDS director, we started to learn a lot about the community level trauma related to opioid use that people were experiencing in Plumas County. We had an incredibly high overdose death rate due to prescription opioid use, high prescribing rate, and we didn't have services that would directly help those individuals. We had little or no access to naloxone. We did not have any providers yet ready to provide medication-assisted treatment, and we didn't have other agencies that were doing specific harm reduction work around drug use and opioid use in particular. And we continue to know that there's a large amount of stigma in the community, but I think several years back there was even less knowledge about the challenges that people who are using drugs are facing, and so that was a real problem for us.
Could I interrupt and ask if the video could be moved so we could see the full slide?
Oh shoot, you can't see it?
Just the video on the right side. Thank you.
Yeah, let me see if I can just. How's that?
You've done it. That's perfect.
Great. So in the summer of 2015, to sort of start having conversations about harm reduction within our community, we were really worried that there would be, resistance to this type of approach of working with people who are actively using drugs and who may not ever stop using drugs. And we wanted to talk about ways that other groups have successfully worked with people using drugs and helped them improve their lives. And so we invited the the group out of Sacramento, Harm Reduction Services, who has a very successful syringe access and disposal program, as well as overdose prevention program, naloxone distribution, et cetera, in Sacramento. And we wanted them to come up and share their experience with our community. And it was an incredibly successful event. We had, we filled the Quincy Library. We had almost 50 people who got to hear about what do syringe services look like, how does naloxone work, how do you administer it. And so here's just an example of a flyer that we used to advertise that event to start these conversations about the importance of harm reduction work. And that's a little newspaper clipping, probably 2 inches by 2 inches in our newspaper. It worked, so people came, and you can read there how we described the event for the community. As time went on, we continued to learn more about what was going on in our community and the risk that we were at for potential HIV or hepatitis C outbreak. In response to the devastating hepatitis C and HIV outbreak in Scott County, Indiana, the CDC conducted a study looking at the factors associated with hepatitis C incidence, and they identified 220 counties throughout the nation at particular with high vulnerability to an outbreak. When we found out that we were identified as a county in the study, the Department of Public Health notified us, and they also had some recommendations for us, one of which was, you should probably think about, at the very least, having a plan for emergency syringe access. in your community. And if you all recall, that was an initial challenge in Indiana, was getting people the syringes that they needed, after people already started to be diagnosed at a very high rate with hepatitis C and HIV. But still at this time in Plumas County, we were learning this about ourselves and coming to a more fuller understanding of what we knew we needed to do and what our duty was as a health department to our residents. But we still, didn't have any access or disposal services available for people using syringes in county, not even for people using syringes for medical use. There was no way for diabetics, for example, to dispose safely of their needles. We were also a really important way that we learned more about how people were using drugs in our community was through the data we were collecting in our naloxone distribution program, where we asked people who received naloxone the types of drugs they were using and how they were using them. And it was very clear that many people who were injecting heroin hadn't always inject heroin, and they started by using prescription drugs, and then they it may be injected their prescription drugs, and then they started using heroin or a mix of things. And we really, it was easy to see that we didn't have two discrete populations. We didn't have, prescription use folks and heroin use folks. It was along a continuum, and that as a health department, we needed to respond to everybody. Here's a map that was that goes along with the study that I mentioned that the CDC conducted. You can see Plumas County identified up there. I feel pretty confident that if they ran our data through their predictor tool now, that we would not show up. And that's really exciting to be able to say. I mean, our death rate has decreased, our prescribing rates have just decreased drastically, and we've increased the types of services that save lives. I'm just going to breeze through this a little bit because I want to get to more specifics about our syringe program. But we were very fortunate to have our Opioid Safety Coalition funded by California Healthcare Foundation and the California Department of Public Health. And when we first launched our coalition, we started with 3 action teams focusing on naloxone distribution, increasing access to treatment, and improving safe prescribing in our communities. And our coalition continues to be a 4-county coalition where we work very closely with our neighboring partners. One of the things that was going along sort of in tandem with the development of our coalition work was the embedding of harm reduction approaches into our community planning processes and our agency level planning processes. So, for example, here's just some images I took from our community health assessment. Every 3 years, we conduct a community health assessment to take the pulse of our community and understand what's going well and then where the health challenges exist in our communities. And here I just pulled out, our prescription opioid death rate from 2013, as well as a comment from a community member. This process includes a number of focus groups and community forums and targeted interviews with residents. And you can see this comment here that a community member provided during the process of conducting our community health assessment. And they're talking about overprescribing and a near-miss overdose with their own mom. These are some images, some pages taken from our community health improvement plan. This is the process that we go through with numerous community partners, behavioral health, social services, our schools, our crisis centers, to align what we're all doing with what the need is in the community. And so what's really great about this process is that everyone really comes to some consensus about what's important and how we are going to most effectively approach those problems together. So here I just have circled multiple different places where harm reduction and stigma reduction are appearing and in our community health improvement plan, which was created with a very large group of stakeholders. Similarly, this isn't meant for you to be able to actually see it in any detail, but here's our agency strategic plan and a couple pages out of there. In the center page on the bottom, there's a strategy that just says create a comprehensive system of harm reduction and treatment services for individuals experiencing opioid addiction. So that's what we've been working on, and it appears in our agent strategic plan as an agency, and putting it in the agency strategic plan really helped get the buy-in also from our entire staff who participated in this very interactive process to create the plan and understand the things that are important to our community and how our own agency would participate in improving the lives of residents here. So as I mentioned, the Plumas County Public Health Agency and the Northern Sierra Opioid Safety Coalition, support harm reduction. And in 2017, we reorganized, we engaged our coalition members in some activities to reorganize the coalition into 2 action teams. We didn't have the bandwidth to continue to have more than 3 action teams, and we wanted to find a spot for some new funding that we had for youth prevention work, but also we had recognized that we were going to start working on planning for our syringe access and disposal program, and that work needed a home in our coalition. And so we created 2 action teams where there once were 3. So now we have the prevention action team and the harm reduction action team. And within the harm reduction action team is where we have worked on our syringe work. So here's just some images from a coalition meeting where we engaged partners in looking at the types of interventions that we were going to focus on as a coalition, including syringe access and disposal. And here they are placing those interventions on sort of a continuum and thinking through how they wanted the coalition to be organized. This is a picture of James Wilson. He is our incredible opioid safety coalition lead. He's one of our senior health educators in the health department. So in late 2017, we applied through California Department of Public Health Office of AIDS for our syringe exchange certification. And simultaneously, we also worked with the Office of AIDS to apply through HRSA for some funds to purchase a van that we would use in providing a host of harm reduction services. And so, doing this was scary for us, and I was afraid as a new public health director that someone was going to get mad at me, or I was going to have angry community members, or I was going to have a lot of not in my backyard sort of opposition. But there's a lot to lean on here, and so this is just a snip from the California Code of Regulations, Title 17, which help guides our work as health departments. And I just highlighted really a communicable disease control portion here, and how it's our duty to provide appropriate preventive measures for particular communicable disease hazards in the community, so of which we have identified some. So it's nice to know this is here. We can lean on it if we need it. Similarly, California Health and Safety Code has Chapter 18 about clean needle and syringe exchange and the incredible evidence behind such programs. And also, I always like to lean on the 10 essential public health services as defined by the CDC. And if you just read through these, you can really see that harm reduction is a core type of value, really, that is embedded in all the things that we do with public health. So if you're thinking about, monitoring and understanding health status, understanding the issues that you have in your own community, and informing and empowering people, mobilizing your partnerships, developing programs, it really fits quite squarely in what we do as public health. Here's a picture of the van that we purchased. This was one of its inaugural days in the community where we partnered with our local hospital who was hosting a health fair. And so we participated in offering hepatitis C and HIV testing at that event as a way to first bring our van out into public and let the community get to know the types of services that would soon be available. So it goes without saying that throughout the last few years, we've engaged our community in our entire process for how we've started thinking, from when we started thinking about syringe access and disposal to actually launching a program and maintaining a program. So we always advertise our coalition action team meetings. These are public meetings that anybody can attend and the community is welcome to attend. As I mentioned, our opioid work and syringe work in particular has been embedded in the planning processes we do as both an agency and a community in our community health assessment, community health improvement plan, and strategic plan. And probably, the scariest thing for me was regularly updating our supervisors. Again, as a new director, I didn't know them super deeply, but I was worried that there might be some opposition. And so, we often had supervisors attending our coalition events, which was fantastic. And then as a director, I regularly attend our supervisory meetings. And so I was able to provide updates periodically, such as, letting them know where we are in the planning process. And, the day that I announced to them that we had applied for certification through the state and that we would be, entering into an open comment period, I was, really sort of light-footed in the language I was using, and I was sort of leaning more on talking about disposal because I know that many of them have gotten requests from community members for years about their inability to dispose of used syringes. And one of the supervisors in the meeting asked me a question, and she said, you're talking a lot about disposal, what about access? I know there's a lot of people who actually need needles, and is there a way that we can get those tools to them? And that was just a fantastic surprise that I didn't expect, and helped me feel a lot more comfortable in moving forward. As we planned the program, we conducted focus groups with community members who were injecting drugs, and we partnered with our district attorney's office to meet people who are currently in our county jail who injected drugs. And we met with a men's group and a women's group to talk with them about how they would most like to receive services, where they felt safe doing so, and any other things they wanted to share about what would help them best receive those services. We continued to partner with our newspaper. Our newspaper has covered our opioid coalition since its inception, and we advertised our open comment period there, as well as in various other communication methods that the health department has. We did, before the open comment period started and after we had submitted our application, and we had a few days before the state was going to officially open that. Last year it was, I think, a 90-day period, so we had a little longer of a time to, be nervous. But we engaged our sheriff and district attorney, our health officer, and a few other partners in a meeting to make sure that all of us were on the same page about why we were doing what we were doing, why it's important, and how we were going to make sure to keep participants who came for the services safe, so that anybody who was seeking to improve their health was not ever harmed further for having chosen to do so. And that as a health department, we enjoy incredible support from both our sheriff's office and our district attorney. And in fact, the same morning that I announced to our supervisors that we had applied and that we were about to enter into the open comment period, our district attorney who came in the beginning of the meeting and provided some comments about the level of drug-related offenses that they were seeing as the DA's office, and how this is really, you know, a frightening indicator of potential health effects due to drug use and injection drug use in particular. So it was a really nice way that the DA supported our planning process. And another thing that we planned to do, which we did do before we formally launched, was we toured the van around the community. We advertised syringe take-back events. So before we did any distribution, we collected thousands and thousands of used needles that community members had been saving for sometimes decades, because there was nowhere for them to dispose of those. And so it was a really nice way to sort of slowly roll the van through communities and let people have a chance to become a little bit more comfortable. Here's a little snapshot of the newspaper article that we published that talks about our syringe plans and invites community members to participate in the open comment period. And so we were certified. It was fantastic. After we received this news, I asked the CDPH for the letters that we received, or the comments that we received. And you know, after 90 days, we had 6 letters, and they were all positive. So that was really fantastic. And I wanted to see them in case some of them were negative, so that we could be prepared to how best to continue to communicate with people who might disagree. But among that group of letters, we had no dissension. So we launched our program in June of 2018. We have 3 fixed sites. They're located at our crisis centers within the community, and we bring our van there twice a month for 2 hours each time, from 3 to 5 p.m. at those sites. We also have a mobile service that's available officially twice a month upon community member request. We have had requests that happen, you know, outside of the days that the mobile service is available, and we've been able to accommodate people who arrive at one of the fixed site, but not during the hours that we're actually there. And so then the crisis center can call the health department, and we can send somebody out to accommodate that individual's needs. So far, that's worked out. And below is just a list of the services that are provided during our syringe access and disposal programming. So on our first day, I just gave it away a little bit, but on our first day of services, I was at the courthouse, and I was really excited to go see how staff were doing at the crisis center site, and how the program was set up, and just how the first day had gone. And I come out of the courthouse to this, and I think, oh no, you know, there's a problem. But luckily, this was not a scene due to our syringe program launch at all. There was a non-injury crash at a neighboring building, and there was a lot of response. But right across the street, our syringe program was operating just fine. And our first client that came in to our syringe service on that very first day was a parent with her 2 children, and they had these 2 needles that they didn't know what to do with for some time, that they had used to vaccinate their horses. And so this was our first disposal success, and the mom dropped these 2 needles in the bucket, and the kids were very excited to see you know, how we were going to, you know, deal with these needles, and they asked a lot of questions about what the disposal was like, and things like that. And later that same day, you know, closer to 5, a second individual came in, and they were there on behalf of a friend, and they didn't really have a clear sense of the types of tools that their friend who injects heroin needed. So we were able to give that person a variety of safer injection supplies to bring to their friends. So it was a very successful and very mellow first day. And we've learned a lot in the first 6 months of our program. So you can see we have pretty low numbers of, you know, unique clients Our data show that we've helped 41 individuals. Not all of them have answered the the questions or wanted to participate in giving us any information. We'll serve them anyway, of course, and we're happy to. We don't require that people answer these questions, although we really like to have the data. And you can see here, one thing that we have done very deliberately is separate our program into two programs. We have a disposal program and we have an access program. And these serve overlapping yet quite distinct groups of people. And there's not really a way that makes mathematical sense to calculate an exchange rate, and that's just fine with us. These are different groups of folks. You can see that row at the bottom, unknown. We suspect that a large proportion of those folks that have not filled out or wanted to answer any of our questions do in fact actively use drugs. And so you can sort of get a sense of what the numbers have been like so far in our first 6 months. And here's a slide that gets to the earlier question about funding. Because we have multiple different sources of funds that allow us to do a host of different activities that keep our communities safe. Really, the act of giving or taking a syringe really takes just a minute. And so we don't have a particular funding source that is for that action per se, but our staff who go to the sites are providing many other services, such as outreach for testing for HIV, for example, or they're doing overdose prevention, education and naloxone distribution, or they're talking about how treatment is available and how an individual might get access to that. So our staff are funded by several different funding sources, and then you can see some of the other amounts that have been spent so far. We do have a subcontract with our crisis centers. This is largely so that they are able to continue to participate in distributing naloxone to community members who go into the crisis center at any time. And then you can see the amount that we spent on disposal, our travel, and just sort of an estimate of the year, the cost of the program per year. But really, the Ryan White services and the coalition services, we would be doing that anyway. So this is just a broad stroke guess as to what it might cost to run a program. And I think, if we were just doing the syringe program, these numbers would look a little bit different. So I think I just have a slide or two left. Really, what I want to share here, and which I hope is clear, is that best practices are really well defined, and there's a lot of support available for counties who are excited about doing this work. As I mentioned, you can lean on the laws that we have in place in our state. That's fantastic. And there's also so many really well-seasoned harm reductionists throughout California. Our staff went and shadowed multiple different programs in different parts of Northern California to continue to become comfortable with doing this work. We also prioritize sending staff every other year to the Harm Reduction Conference. This last year it was in New Orleans, and we sent 5 staff, and it's just a fantastic opportunity for them to continue to learn how to do really good harm reduction work. We also couldn't have done this without the Office of AIDS, the Safe and Active Communities branch, and the fantastic deal it is to be part of the clearinghouse and being able to get our supplies through that mechanism. Also, almost entirely our materials and policies and procedures related to our programs have been borrowed and stolen from other successful programs and just adapted for our rural area. So we saved a lot of time, and the harm reduction community is extremely generous in sharing any and all that is available, so no one has to recreate the wheel. So I guess that's it. Here's another picture of some of our team and the van and our storage closet up in the public health offices. One thing that I will add is that, you know, we do have our fixed site and our mobile services, but what we have learned in the last 6 months too is that many people who use drugs are actually more comfortable coming to the county building where the health department is. There's multiple departments in the Health and Human Services building, and it has become obvious to us that this is a safe place for many people, and that it actually feels more safe perhaps than some of our other fixed sites where it could be more easily discerned that they were there for a particular service. And so we've had individuals come in to the health department and say, hey, I don't actually even want any needles, I want treatment. And this was the only place I knew where I would feel safe coming in to say something like that. And so we continue to have successes with that. And we're now working on what the policy and procedure is for when people walk into our public health clinic or our public health administrative offices asking for harm reduction services, and how we'll accommodate that on site here. And so here's a thank you to our staff, coalition members, the harm reduction community, and our multiple funders. And thank you so much for inviting me to share our story.
Hi, Andrew. That's really impressive work among a large number of stakeholders with, I'm sure from the beginning, very different perspectives about the merits and hazards and risks of implementing the various components of a harm reduction program. I'd like to open up. We can have folks ask questions. Anybody? I've got a couple. Let me ask mine first. I notice Aegis is a supporter. What about Anthem Blue Cross? Because the costs of failing to reduce harm can be substantial. Do you guys have a foundation and an interest in? I'm going to find out more about. We need to have you talking to them.
Oh, sorry. Come
on up here.
Sorry about that.
Okay, come on up here.
Do you want me to use this still?
Probably better. Leave it up here. One more time, reintroduce yourself.
Oh, sure. So my name's Diana Linscomb. I'm actually the program manager for Tuolumne County. And Anthem does have a foundation. I myself am not as familiar with what the foundation actually supports as far as funding, but I wrote that down as one of my take-back questions, is to find out what would they fund. And I will bring that back at our next meeting, if that works. Okay.
Did you have any questions?
I don't. I was very impressed. I actually live in Tuolumne County, so it's dear to my heart also, because I do reside here. And so now these were great presentations. Thank you.
Anybody else? Andrew, can you hear me?
Yes.
So I have a question. I didn't see anything about engagement with commercial pharmacies or private pharmacies. Can you say something about that?
Sure. So our health officer is here too, and may be able to add something. You know, when we first launched our coalition, we thought that a really low-hanging fruit would be to engage our pharmacies in the region and see if they were, you know, willing to, you know, provide syringes. And, you know, really the answer was no, and that nowhere was doing that. That changed slowly over the last few years, and we started learning that a few champion pharmacists were routinely selling syringes, and so that was, you know, a nice development. Our relationship, I think, continues to deepen with our pharmacies, at least in Plumas County, as we've engaged in, you know, increasing access to medication-assisted treatment and needing to partner closely with pharmacies so that that goes smoothly for people as well. And Dr. Satterfield, I don't know if you want to add anything.
Not too much to add except to say that, yes, it's been heartening to see the engagement of our local pharmacies, the independent pharmacies. It's been a little bit more of a uphill push with Rite Aid, which is the big pharmacy in town. But the independent pharmacies have been great partners by and large to that, and in our work with MAT as well.
Right. And we also were very fortunate in that one of our pharmacists participated in the academic detailing training, and she was able to go around our coalition region and train other pharmacists about naloxone and the laws surrounding that, and the ability of pharmacists to participate in providing naloxone to individuals at risk. And so we're really fortunate to have that pharmacist in county.
And I have another question. In identifying the 3 fixed sites, did you encounter difficulties trying to locate sites in other settings besides the crisis centers?
You know, that's a good question. So when we talked with individuals who use drugs, we had already had an offer from the crisis center to partner, and they had always been very vocal that they would love to be a partner on this program. And so when we asked people who use drugs where they would feel safe, that was one place that people suggested. But when we said that it was an option, it was acceptable to people as well. Many people had already received multiple types of services from the crisis center, such as, you know, food or housing assistance, showers, things like that. And so it made sense for us. We don't have a lot of other locations that we felt would work. And so we're trying this now. It doesn't mean that we might not adjust in the future if we come up with something better or something that people feel more comfortable with. But we were really lucky in that our crisis centers had already been partnering and a part of our coalition in doing naloxone distribution, and they were regular attendees of those meetings. And so it was a good fit. But that said, you know, we do conduct continuous training with the employees there, so that, you know, as employees at the crisis center turnover and they are, you know, newer to harm reduction work, that they have the best understanding that they possibly can, so they can support us when we're there on site.
So I have 2 other questions. One, in the period up to the present time, and perhaps in advance of the harm reduction program, how much data did you have about needle stick injuries for waste management folks, law enforcement, first responders, and others? And do you have a way to say that that's been reduced?
That is a great question, and I don't have those numbers in my brain or in front of me now, but I think it's something that I could probably find and follow up on.
Okay, great. Thanks.
If I could just add to that real briefly, you know, there have been studies in other parts of the country on those subjects. I mean, I think intuitively, you know, one thing to keep, Andrew sort of had a really good anecdote from the development of their program about how when they made the service available and started doing syringe disposal kind of take back stuff before they started distribution, they got a huge number of syringes in, because unfortunately we are one of those states that makes it weirdly difficult to safely and lawfully dispose of syringes. People are supposed to mail them back in, you know, an FDA approved Sharps container, which is just, you know, not even kind of thinking about people who inject illegal drugs, but just normal folks using for, or other normal folks using for medical purposes. It's a big barrier. So just the presence of these services does a lot to get, you know, used syringes out of circulation, and particularly if, you know, a lot of thought is going into how to make it convenient and accessible for people to dispose of syringes safely as soon as possible after they've used them, I think we've got a lot of opportunity to do that and reduce, syringes out there. There also have been studies of this that have shown, like there's sort of one famously from Connecticut, where there was a statewide shift in policy to decriminalize syringe possession. There was a bunch of kind of training that went along with that to law enforcement during the time of sort of a commitment to scaling up syringe access services also. And there was a documented decrease in law enforcement needle stick injury that followed that. And, again, there's an intuitive thing to this. And basically what was happening was that people became less fearful of hiding syringes from officers. A huge part of a sort of officer's job is searches. Maybe not a huge part, but it's a common thing that folks do. And so this just sort of removed a barrier to people like identifying that this was on their person, and sort of minimize that risk to the officer doing the search. So, and we've seen that play out in a number of different ways.
So my last question has to do with what's the best way to express this? Safety, prevention of injury or theft at the crisis centers where disposal and access activities take place. Is there any in the course of your work so far, or Matt, from the statewide point of view, is there any evidence that establishing disposal and access sites it provides an opportunity for crime?
That's nothing that we've seen. No, it's been real mellow, real positive. No problems at the sites.
Yeah, I mean, I think that's what you see all over the country and all over the world. A sort of well-functioning harm reduction space is a space that, whatever else is going on for people in their lives outside, stress and kind of worry and stuff like that, or other things, harm reduction spaces are places of respite for folks. You see a lot of smiles and normal conversation and stuff, and people are pretty protective of those services and the spaces that they occur in because they really care about them and value them. So I think you tend to see sort of the opposite of a sort of contentious or crime type space, whatever that is.
Yeah, and just to add one more thing, the most common thing that we hear from participants who come for services is thank you. Thank you so much for being here.
Okay, we have one last question, if we can.
Sorry. So it's kind of to the group too. I believe that Tuolumne County has a drug, the Dropbox, right? So I was curious if Plumas County had ever considered, or have you thought of for the syringes, a Dropbox, similar to the drug take back programs Dropbox?
Yeah, so we have been thinking that through. We do have drug take back boxes that we have at some of our sheriff's substations, as well as our pharmacy sites, and that has been successful in collecting medications. And we have a couple extra kiosks, and we can order a few more. And we just haven't identified the locations yet where we want to put those. We know that, like I mentioned earlier, that people feel safe coming to the county Health and Human Services building and requesting syringe access and or disposal services. And we wanted to continue to increase access to disposal options even in after hours. And so right now I'm in discussions with the other department heads that share this building with me. Behavioral health, social services, environmental health, and probation are all in the building. And we're discussing where the best location for such a kiosk would be on this particular county campus, and where those departments would feel comfortable and where their staff would feel comfortable. And so there were some concerns from behavioral health just because our entrances often have family and children and they didn't want like a spill of needles or something like that. And so right now we're gonna get together with them and explain what our safety procedures are to help everybody feel more comfortable. And so we're looking at a location that could be accessible outside any time of day for people who want to dispose of used needles. But we have yet to install those.
And if anyone's interested in that stuff, we with NASIN, the North American Syringe Exchange Network, which administers the supplies clearinghouse, did a little bit of costing out and identifying suppliers for different kinds of sharps disposal box options. So ranging from the kind of outdoor kiosks that Andrew was just describing to the very simple wall mount ones that you find pretty much everywhere in any airport in the country. So the options for purchasing them are often quite inexpensive. Disposal, if it's not a huge volume, is relatively cheap. So if anybody wants more information on that, I'm happy to share after the call. Also, I just want to point out we do have a couple questions on the chat, so I don't want to miss those before we quit.
Hi, Neil Evans with Tuolumne County Sheriff's Office. One question for you. Obviously, this is a very positive presentation. Was there anything that you learned from this, any mistakes made, anything negative that we can learn from and not make the same mistakes?
I think that's for Andrew.
Yeah, I mean, like I said, I think in public health, we're really fortunate here, and this sounds like maybe it's very similar in Tuolumne, that we have a really close relationship with our sheriff's office, and it's fantastic that we really were able to identify our shared goals, in that we want to keep our communities safe, and that with particular populations we have to work together. And so we made sure that our sheriff's office and DA's office were also aware of the paraphernalia laws and things like that, because we really didn't want people, as I mentioned earlier, to be harmed in the process of trying to improve their health. And so we just really tried to keep those communication channels open, and we all at this point understand that. And we haven't experienced any problems to my knowledge yet, nothing that I'm aware of where someone was arrested because they had certain supplies that were going to help them be safer. But I would encourage that conversation to continue.
There's two little quick questions from Mark Horton over the chat. First one for Andrew: is your needle exchange program one-for-one or as needed?
We do a needs-based program, and so whatever people need, we are happy to give it to them.
And that is also both the policy of the California State Health Department, the CDC, basically kind of everyone agrees that that is the appropriate way to approach this. I think the way Andrew described sort of bifurcating the projects of distribution and recovery and disposal is a really good way to think about it. They are closely related, but importantly different activities. And then the second question, I guess, is for me, is the certification program time limited? Does it need to be renewed periodically? Programs that are authorized either by the state or local authorities need to be reauthorized every 2 years. The process for doing that at the state level is very simple. Basically, the program sends us an email before their authorization expires, requesting reauthorization. We do a quick check-in with the same folks that we consulted originally during the public comment period, which again is typically the sheriff's department and the health officer, and then we reauthorize that program. There's no new public comment period or other review like that.
Great, thanks. Thank you.
Okay, thanks everybody. Really appreciate it. So Andrew, you'll later on let us know how to access the archive version.
Yes, yeah, we've been recording, and I will work with staff here to figure out what the easiest way is to make that available for everybody.
Thank you so much. Everybody, thanks very much for attending. And Kismet, are you still there? Okay. So thanks again. We're going to close down.
Good job. Thanks.
Have a great day.
Very much.